Assalamu alaikum. Welcome to Journal Club of this week. I'm going to present a case report of histological assessment of unsuccessful regenerative endodontic treatment published recently in European Archives of Pediatric Dentistry. The patient is a 70-year-old girl sustained an uncomplicated crown fracture and lateral luxation of maxillary right central incisor following a fall. Initial examination showed normal tooth position, positive pulp sensitivity, and no radiographic abnormalities. 4 months later, the tooth developed buccal swelling, grade discoloration, increased mobility, and loss of response to pulp tests. Radiographic examination revealed an immature root with widening of periodontal ligament space, leading to diagnosis of pulp necrosis and apical periodontitis. Following abscess drainage, the patient was referred for endodontic management. The endodontist opted for regenerative procedure over 2 visits. Following regenerative endodontic treatment, the tooth remained asymptomatic but showed no response to sensibility testing and no radiographic evidence of root maturation, apical closure, or dentinal wall thickening during the first 2 years. By the 3rd year, progressive mesial root resorption, infra-occlusion, and metallic percussion sound indicated ankylosis and replacement resorption. At the 4-year follow-up, infra-inclusion and root resorption had progressed further with no continued root development, leading to a conclusion that the regenerative procedure had failed. The tooth subsequently was extracted and examined histologically. The overall finding was that tissue inside the canal was highly heterogeneous and bore only limited resemblance to a normal bulb dentin complex. Instead, it consisted of a mixture of fibrous connective tissue, bone-like tissue, dentin-like tissue, blood vessels, nerve-related structures, inflammatory cells, resorptive tissue, cholesterol crystals containing cysts. In the first picture here, we see that the newly deposited hard tissue was markedly abnormal. It has irregular architecture, amorphous appearance, variable tubule density and tubulal width, and disorganized layering. Active internal and external inflammatory resorptions were evident. One of the most important findings was replacement resorption. The bone cells entered through the apical foramen, bone tissue grew into the canal space, and external bone became continuous with internal mineralized tissue, and the normal periodontal ligament was lost in the affected areas. Cholesterol crystals was the most unusual and novel observation in this study. Numerous fibrocystic structures were identified within the middle third of the canal, with fibrous cyst walls, lumens filled with cholesterol crystals, and multiple crystal deposits clustered together. For the immunohistochemistry, it demonstrated persistent inflammatory cell infiltration throughout the root canal space, including macrophages, lymphocytes, neutrophils, fibroblasts, and multinucleated giant cells. The degree of inflammation varied from mild to severe across different regions, indicating a chronic low-grade inflammatory process despite the absence of clinical symptoms. For the S100 immunostaining, it identified Schwann cells-associated structures, hyalinized positive regions, and neural tissues components within the intracanal tissue. These findings indicate neural ingrowth and ongoing neurogenesis with partial re-establishment of innervation. However, the regenerated neural tissue was insufficient to restore a positive response to pulp sensitivity testing. In conclusion, regenerative endodontic treatment produced abnormal mixed tissue rather than true pulp dentin regeneration. The histologic examination showed root resorption, ankylosis, and cholesterol crystal deposit, which is a novel findings and could be a nidus for persistent inflammation.